Hello and good morning. Thank you for joining us today for our number 7 of our webinar series that we've been doing on a weekly basis. So today we're going very technical a little bit. We've veered off a little bit from the QA topics, but this is still good and core of lab. My name is Antony Jaccodul. I'll be your moderator today. And with me, we have Haroun Ayub will be the presenter. And we also have John Keane, who is the Africa manager for Hemex Health. Maybe virtually John will have an opportunity to introduce himself before we proceed. So let me allow Haroun to introduce himself, and then John, and then we'll proceed. Thank you.
Thank you, Antony. Good morning, everyone. I am Haroun Ayub, Technical and IVD Manager at Keton Consulting. I'll be taking you through today's session where we'll be focusing on diagnosis of sickle cell. And our main diagnostic feature we'll be focusing is on HB electrophoresis using Gazelle. Thank you. Over to John.
Good morning, everyone. Thank you so much, Jaccodul. My name is John Keane. I work for Hemex Health as the Africa head business. It's a great pleasure to be invited as a guest to this session. We're going to discuss about sickle cell anemia and HB electrophoresis as an impact tool, sickle cell anemia. I look forward to a fruitful engagement and feel free to ask as many questions as possible. Thank you so much.
Thank you very much, John and Haroun. So as usual, we normally start on time so that we are able to cover as much as possible and also allow for Q&A. So we'll have a session from now to 8, and then for the 30 minutes from 8 to 8:30, we'll be able to have a Q&A session, and then we'll be able to call it a day. So virtually, I'll hand it back over to Haroun so that we are able to start. Thank you.
Thank you, Antony, and good morning, everyone. So we'll be able to start today's session. My presentation is clear and visible to everyone.
Yes, it is.
All right. So for today's session, we are focusing on mainstreaming sickle cell testing, affordable electrophoresis for all. So we'll be focusing on sickle cell diagnosis, and as indicated, electrophoresis will be our main focus. And today we are discussing on HB electrophoresis by Hemex Health, India, USA group. So our objectives for today's session, we'll be focusing on sickle cell testing, the definition, its epidemiology, pathophysiology, diagnostics methods, and Gazelle HB electrophoresis as indicated. So let's start off with what is sickle cell disease. So this is it belongs to a large group of blood disorders known as hemoglobinopathies. Hemoglobinopathies are inherited conditions that are characterized by abnormal formation of hemoglobin protein chains. In sickle cell disease, a genetic alterations affects the beta globulin chain. So we'll focus on the several chains that we'll be focusing on. And for SCD, the beta globin chain is what is majorly affected. This will lead to production of abnormal hemoglobins, which we'll be calling as HBS. The abnormal hemoglobin results from a specific point mutation where the amino glutamic acid is replaced by valine at the 6th position of the beta globulin chain. So this will form point of the diagnosis, and when we are doing genetic testing, this is usually what the geneticist or the lab technician will be focusing on when doing PCR or molecular diagnostic for SCD. So in a nutshell, this is the overview of the normal red cells and the normal hemoglobin forming this particular shape, while the sickle cell shaped hemoglobin will form HBS. So this sickle cell kind of shape is what is we are referring to as hemoglobin S. And you will see that it affects the hemoglobin that are inside that particular red cell. So normal red cell, sickle cell shape, and how they pass through the blood vessels. This is what usually causes the disease aspect of it by blockaging, since they are usually sticky and their shape is distorted. So the normal shape will allow them to squeeze between the vessels as they pass, while this particular sickle shape, cell shape will prevent the movement. So the variants for the human hemoglobin, we have HbA. This is composed of 2 alpha and 2 beta globin chains. And then we usually have HbA2 made up of 2 alpha and 2 delta globin chains. Then we have fetal hemoglobin consisting of 2 alpha and 2 gamma globin chains. During the first year after birth, HbF is the dominant one and usually recedes beyond infancy between 2 to 4 months. So while we are testing for hemoglobin F maybe in infants, you'll find that the highest percentage will be HbF, while HbA now replaces that particular HbF, and it accounts for around 96% of the total hemoglobin for normal normal healthy individuals, while HbA2 will represent about 2 to 3%. So it's very normal for us to get a representation of between 2 and 3% for HbA2, while HbA for a healthy individual will be around between 96%, so either 96, 97, while the other percentage will be HbA2. So our total percentage will usually sums up to 100%. And usually it forms part of the principle for Hb electrophoresis by the Gazelle analyzer. So presence of HbS defines the condition known as sickle cell disease. So as long as you have the HbS variant, you will be referring to it as sickle cell disease, but their representation is in 2 forms. So we have the sickle cell anemia. This is the homozygous form where both hemoglobin genes are HbS. So we usually have the homozygous representation of SS when you are representing your results, and usually that's the first form. So SS means that the highest percentage of that particular individual is sickle cell sickle cell disease. These particular individuals will have little to no normal HbA variant. Then sickle cell trait, so this is represented as AS. It's a heterozygous condition with 1 normal hemoglobin gene and 1 sickle hemoglobin gene. So you have HbA and HbS. And during diagnosis, you'll see how the percentages are represented and how the doctor will make the evaluation or the lab report. So these particular individuals who have the sickle cell trait typically show no symptoms unless exposed to low oxygen levels. This is where they'll start experiencing symptoms or struggle to maintain in that particular situation. While sickle cell anemia disease, the SS homozygous form will have the representation of the disease or the representation of the symptoms from the onset. We also have sickle cell beta thalassemia. This is another heterozygous variant where the amount of normal hemoglobin exceeds that of the sickle hemoglobin, resulting in a milder clinical representations. And all three conditions you will see being reported in the electrophoresis report. So as we have said, the adult hemoglobin HbA will consist of the alpha and beta, 2 alpha, 2 beta globin chains. The normal representation will be between 95 to 98%, while the other percentage will be represented as HbA2, the minor adult hemoglobin. So the structure is alpha 2 delta, normal 2 to 3.5%. This also forms part of the report. In case this particular number is changed, it will give us issues to do with beta thalassemia. So in terms of diagnosis, once you run electrophoresis or HPLC, high performance liquid chromatography, you'll be able to see these percentages and they will help in diagnosis. So usually a high HbA2 above 3.5% will suggest beta thalassemia trait. So in terms of reporting, this particular individual is normal. They have 90% of A, HbA, an adult, but they have maybe 10% or 9% of A2. So that one is usually representative of beta thalassemia trait. So absence, to take you back, so a complete absence of HbA will be represented in HbSS patients. And we have HbF, where we have said 2 alpha and 2 gamma. It's predominant hemoglobin in fetus and newborns. Adults will have less than 1%, except in certain disorders. Protective role in ACD inhibits HbS polymerization. Hydroxyurea and newer drugs like voxelotor, crizanlizumab, and gene therapies work partly by increasing HbF. So while in the lab and you're testing a non-sickler, usually the doctor will be focusing on checking how the patient is responding to the medication. And they will focus this by looking at the HbF representation in the total count of the variants. So at the lab, you'll find that once you did the first diagnostic test and the patient was confirmed either a sickler, complete sickler, or a AS trait, you'll find that after, let's say, 3 months, 6 months of therapy, mostly in our region, we are using the hydroxyurea, you'll find that this particular number usually goes up, the HbF. So if the HbF goes up, it limits the HbS, meaning that the patient is responding. But you will not expect that a non-sickler will have, while doing this hydroxyurea therapy, we are not healing the patient to start producing normal HbA. As long as this is genetics, you'll find that the patient will continue producing that particular S, and the hydroxyurea therapy is just managing the patient to inhibit HbS polymerization while increasing the HbF. So while monitoring, HbF usually goes up while S percentage goes down, and that's usually a good sign. But when you find that S is going up and F is going down, it means the therapy is not working, and it guides the doctor to either increase the dosage of the therapy or use alternative means if the hydroxyurea therapy is not working. While HbS, the sickle hemoglobin, it occurs through the mutation of the beta globin gene. This one we have said, and it's in codon 6. When deoxygenated, the HbS polymerizes, causes the sickling of the RBCs. So that S shape, the C shape that we usually see. The homozygous form HbSS, sickle cell anemia, that's confirmed, while heterozygous form of AS will cause the sickle cell trait, usually asymptomatic, unless we have said you go to regions with low oxygen, then they'll start feeling it. HBC, this is a mutation of the beta globin gene, also happening in codon 6. It's homozygous HBCC, causes mild hemolytic anemia. Compound heterozygote SC will cause sickle cell and HB disease, often milder, than HBSS, but clinically significant. And usually the HBC and HBE usually is not within our region, let's say East Africa, Uganda, Kenya, and maybe Tanzania, but usually forms part of the Arab region and the Indian region. So in terms of diagnosis, and if you find this one, you need to find out if the person is coming from those particular two regions. That's where it's commonly found. The HBE mutation in beta globin gene, also in codon 26, it's common in the southeast of Asia. HBE trait is benign, but HBSE, sickle cell disease, can mimic sickle cell disease representation. So in typical HB electrophoresis or HPLC pattern, so HPLC will see it's part of the diagnostic form of sickle cell. This is the high performance liquid chromatography. So a normal adult will represent between HbA of 96 to 98%, while having HbA2 of between 2 and 3%. So at any point you find that HbA is represented as 100%, this calls for a retesting because a normal adult will have a representation of this nature, while HbF might be present, but it should be less than 1%. The sickle cell trait, HbA will be at least greater than 60% or within 60%, while HbS will be about 40%, while the HbA2 normal and HbF gives a small percentage. So this is what will represent as a sickle cell trait. So they have a higher percentage of A as compared to the S. In sickle cell disease, we'll find that the highest representation is the HbS, greater than 90%, while HbF is variable in children, and no HbA or HbA2 will be slightly up. So complete absence of HbA will refer to the that particular sample or the patient as HbSS. In HbSC disease, we find S at 50%, C at 50%, with little or no HbA. HbS and beta thalassemia, you'll find HbS plus a combination of HbA2, which is increased, or little to no HbA. So we'll be able to see how the analyzer is able to differentiate between the CE and A2, which usually co-migrate, and then we'll have the S and A bands and A2 bands. So the SC disease will be characterized by absence of normal hemoglobin, composed of hemoglobin variants, the S and C. The symptoms will resemble that of sickle cell anemia and tend to be milder. Ranks as the second most prevalent sickle cell disease. HBC variant arises from mutations of similar to HBS, except the glutamic acid is replaced by lysine. So this is how the representation of fetal hemoglobin. So at birth, after gestation, so this is the gestation period between 3, 6, then weeks, then after birth between 3 and 6 months. So usually for while running the results for an infant, you'll find that the HbF will be high, but will decrease over time, while the HbA will be rising over a duration. So usually also helps know if that particular aspect is happening correctly or not, and forms part of the diagnosis of the patient. So you'll find that for babies, you'll find that you'll run the testing after birth if the mother is a non-sickler or having a sickle cell trait, but after, let's say, 3 months or 6 months, you'll have to do a retest also to do the confirmation. So this is the summary table that we have discussed on the representation of the percentages. So the epidemiology. So the sickle cell gene has its roots in Africa and India, but due to the increased global movement, it has now become a worldwide health concern, with occurrence of up to about 1 in every 625 live births in the Americans. So why it has been predominant in Africa and India is that because in these particular two regions, being endemic for malaria, you find that the persons who had HBAS or HBSS, they were not having a higher form of the disease, the malaria disease within them. So we find that this particular trait now continued to survive in the generations and being inherited, but now it had other impacts for the SS particular patients who had now symptoms or diseases of the sickle. The regions with higher prevalence remain Sub-Saharan Africa and India and the Middle East. So the Middle East and India, you'll find the SC disease predominant, while in our region, you'll find the SS or the AS. So this affects both individuals, either male or female, equally. On average, individuals with sickle cell anemia develop kidney failure by age around 23 years, and overall life experience usually around 27 years, regardless of whether dialysis treatment is received. So the SCD arises from a single point mutation of the beta globin gene. The red cells carrying the mutations become vulnerable when exposed to oxygen, especially for below 40 mm for approximately 2 to 4 minutes and then they lose oxygen. So this deoxygenation triggers the hemoglobin molecules to stick together through hydrophobic interactions, forming long polymers and distorts the RBCs. So this is usually what causes that particular pain in the individuals when they experience these particular low oxygen concentrations. The stiffened RBCs will block the tiny blood vessels, leading to oxygen deprivation in tissues and triggers more sickling. The cells break down quickly, surviving about 10 to 20 days. The early stages of polymer formation can be halted and reversed in oxygen if restored promptly. However, repeated cycles of low and normal oxygen levels causes damage to the cell membrane, oxidative stress, and permanent sickling changes. So public health burden of SCD, why it's important. Over 300,000 babies born annually with SCD worldwide, 75% in sub-Saharan Africa. Without early detection and care, 50% will die before age 5. Average life expectancy is low in resource settings, above 27 years, and economic burden by high hospitalization costs, lows productivity. So this forms the basis of the webinar, why early diagnosis or detection is important, or screening. So WHO calls for universal newborn screening in high prevalence regions, such as Ghana, Nigeria, Uganda. National pilot newborn screening programs are implemented. In Kenya, pilot projects integration with newborn care, especially in regions around the lakeside or the islands, usually more common. This usually by early detection links to prophylaxis and counseling and increases the life expectancy or survival. The diagnosis usually is in 2 ways. We'll have the screening or preliminary tests, and then we'll have the confirmatory test or the quantification stage. So the screening test usually in low settings or common labs, you'll find that we are using the slide method, the sickling tests. We are using sodium bisulfite or deoxygenation to induce sickling. So we take our sample, we do the slide, we introduce sodium metabisulfite, it will deoxygenate the cells, inducing sickling for sickle confirmed samples or patients. It's simple, cheap, and rapid, can be done within the lab, but its limitation, it doesn't differentiate the trait versus disease and false negatives in neonates due to high HbF. So you'll find that this one will not differentiate or give a diagnosis whether the person is AS or complete SS. Very difficult to do that particular differentiation. We have the solubility test or the Sickle desk. This is based on turbidity of lysed RBCs with HbS in phosphate buffer. It's quick, but also not confirmatory. You'll just get a representation. Yes, there is some sickle, but you'll not be able to differentiate. We have hemoglobin electrophoresis. We'll discuss this further. So this involves separation of HB variants on cellulose acetate or citrate agar gel. This differentiates HbA, S, C, and F disease. And sometimes the limitations, we may not quantify precisely, especially if we are using the gel acetate kind of testing. We have the HPLC, the gold standard in many centers, separates and quantifies HB variants accurately, useful in neonatal screening and monitoring of treatment. We have also the isoelectric focusing, highly sensitive, used in newborn screening, can distinguish HBS. So you find this one is majorly used in Europe for diagnosis. And then we have DNA analysis or PCR, usually detects the point mutation in the beta globin gene, useful in prenatal diagnosis, complex cases, or genetic counseling. So in terms of availability and testings, you find the HPLC gold standard will take between 20 to 30 minutes, usually in central or high reference laboratories. Usually cost per test is usually also very high. You have gel electrophoresis. The average cost is usually average, takes 2 to 3 hours, requires skilled lab and equipment to perform. And we have the Gazelle microchip electrophoresis with low costs. Test takes simply 8 minutes, portable and minimal training required. So on the HbA variant testing, how the analyzer works, Gazelle detects and quantifies the HbA normal, Sickle, H, F fetal, and A2CE. The device will also offer interpretive statements for specific hemoglobin conditions based on test results, including beta thalassemia disease, intermediate or major, the traits, beta thalassemia minor, as well as sickle cell disease and treat. The test results from Gazelles are intended to help clinicians manage patient care, should be used along with clinical information of the patient, such as history, other results, the CBC results, and also physical examination. So the HB variant test for Gazelle is an IVD test for quantitative measurements of A, FS, A2C, and E using cellulose acetate electrophoresis. Uses the HB variant test multipack, including the cartridges that then provide the interpretive results. So you'll find that A will be represented, F will be represented as a percentage as well, S will also be represented as a percentage. A2, C, and E co-migrate. So we'll see how the report gives the A2CE, and you'll find that their representation will be given as a percentage as the grouping together. So depending on how these other particular variants will form, it will determine how the machine will interpret for you the A2, C, and E. So the principle of the procedure. So this is just a miniaturized version, gold standard hemoglobin electrophoresis test. You use a single cartridge incorporating cellulose acetate test strip, the microchip electrophoresis. The cartridge containing the live blood is inserted into the reader. The hemoglobin variants will be separated according to their net charge on the cellulose acetate strip, and within 8 minutes, the interpretation of normal trait or disease, as well as the types of percentages will be displayed. So this is just a microchip of how the card looks like, and then this will be the representation. So we have buffer that is used, and it will allow the strip, the cellulose acetate strip, to migrate when we put it on the analyzer. So the electrophoresis method, you'll find that we have the negative charge and the positive charge, and you'll find that these particular genes will migrate depending on the net charges of the individual variants. So the highly negatively charged will migrate further because they are more attracted to the anode and repelled from the cathode. So the migration will follow a certain direction, and then the representation will happen. So depending on the net charge of that particular variant that we are testing, it will move as represented here. So you find at the first band, you'll find the A2CE band. They'll co-migrate, and they'll be the first to be left behind. Then you have the S, followed by the F, and then followed by the HbA. So the microchip electrophoresis process, the standard is exactly as the gold standard electrophoresis that is used. So it will differentiate depending on the negative charges in an alkaline solution, and they'll move across the paper at different speed after a voltage that is applied. So usually you find that when you're doing the gel electrophoresis, you'll apply a voltage, either 10, 20, or 40 volts, depending on what. So for the machine, it's already calibrated the voltage that it will use, and then the migration will happen depending on the net charges. So we'll briefly look at a demonstration video for the process, and then we'll be able to discuss it. All right. So okay. So that is simply the representation of So this is simply the representation of how the electrophoresis process occurs. Yeah, so I was simply elaborating on how that particular process works. So you'll find that we have only two reagents that we are using. The buffer, remember that is to provide the alkaline environment for the cellulose paper to wetting process and allow the migration. So this is just a miniaturized version of the gel electrophoresis. So if you remember the background of gel electrophoresis, we usually have our gel that we prepare our gel, we place it in a bath, which is buffer, and then we place it on the electrophoresis machine where we'll have the anode and cathode. And then once we place our gel and we start, we check the voltage that we want, and then we set the time that we want, the migration will happen. So simply electrophoresis process also the one that is used in DNA process. So the migration will happen, and then you can compare the migration pattern with another sample, and you get maybe your DNA testing. So the same thing is happening here. So this is just a miniaturized version. We have our card with the cellulose acetate paper. Once we introduce the 50 microliters of the buffer, it will wet the paper entirely. So remember, paper wetting is important to allow migration. So if the paper is not wet entirely or being wet well, it will not migrate. After we do that, the second reagent we have is the buffer, the marker. So remember, the marker fluid forms part of the internal QC that will allow you or will allow us to monitor the migration pattern. So this is formed using material that have different net charge as compared to the hemoglobin sample. So it will migrate as the first one. So we'll look at how the particular machine is picking up that particular video and how the marker will move. So for the machine to accept those particular results, it has to see the marker moving at a certain speed that is calibrated by the manufacturer. And after it has moved, it has to reach at the end so that it can confirm that within the 8 minutes, the migration is correct. So that you don't have within the 8 minutes, the migration has stopped maybe in the middle, and it will give us wrong percentages. So the marker fluid acts as that particular QC. Now remember, this is the first mode that we have for the HB electrophoresis kits. Now, the manufacturer has also gone further and did further testing or received feedback. Now remember, for these ones, you need to do pipetting, you need to have slides, you need to have centrifuge tubes or micropipette tubes. And once you have those particular aspects, you need to now load it on the machine and you get to run. So by that, the advancement that came with that will be now the second video that we look at on the new type of cartridges that are being used. And then we'll look further now on the main point will be the running process. So this is the new version of the kit. So you'll receive your marker fluid, you'll get your buffer, and you'll get your test cartridge that is assembled, the applicator, and the collector. So remember, the first procedure was for the S10 kits, then the second procedure is for the S10B. You'll find that it's clear that the machine will ask you if the patient is an infant or not. This is important because we need to differentiate if the HbF present in the patient's results is because of fetal hemoglobin or it's because of other conditions. So this is simplified. So you'll find that you'll only use 5 drops directly on the paper wetting well. Then the buffer wells, we are putting 5 drops. So this is just giving us the buffer environment to help this particular process migrate. So remember, we have the cathode here, negative, and the positive anode on the other side. So it should allow the migration of the variance through that particular field. So it's forming a continuous field. So we'll put the marker. So this is just the collection of the blood sample. So this can be from an EDTA tube or from a direct fingerprint. So this helps it being a point of care and you can move with it anywhere. So the pipetting or the vortexing or pipetting mixing that we were doing using a pipette or a vortexer is just simply represented by the up-down motion. So this is just the mixing of the blood and the marker fluid. So this is the stamping method. So it's just giving us a calibrated position or calibrated amount of the marker and fluids on the paper strip. So we close the cartridge. This is the stamp that we have presented. So we need to see it migrate over the duration. So during testing, this is what happens. So this is the process. So you'll find that the migration will happen within the 8 minutes and the marker fluid will move fast. Then the bands will start separating depending on the conditions. So you'll find that I said A2CE will be the band that will be formed, the first one. Then you'll find the S band, the F band, and the A band. So you'll find that for HB electrophoresis, it will give us in form of percentages. So this usually helps in terms of monitoring and also confirms the phenotype that we have. So phenotype AS will be represented as a trait because we have normal A and S, and then we'll have, when you have SS, you'll find that the highest percentage of the variant is the S variant as compared to A or A2. So this is a sample of the report. So you'll have the demographics of the patient, and then you'll have the results, and you'll also have a screenshot of that particular run so that you can clearly view the results. So you'll find that usually the bands will separate depending on the condition of the patient. So let's say we are having an A2A of let's say 97% for a normal healthy individual, and A2CE. So you'll find that the small band will appear on the A2CE region, and the last band for A will appear much bolder than this one. Then you'll find the Sickle will represent as a band on the S region and a band on the A region. For fetal hemoglobin, you'll find the band usually about between the two, S and A. Then the A2CE, so if the highest representation of maybe A2 for beta thalassemia will also be represented by a much bolder band. This usually just helps in differentiating them. So why we say we report A2, C, and E together is because they have the same net charge, so they usually co-migrate. So the machine will be able to interpret them based on the other representation of the other variants. So, but A2CE will be represented together. Then we say that we'll give you the phenotype. So the phenotype, there's several phenotypes that are usually reported, about 29, but generally in the world there are about over 100 phenotypes. So you'll find the phenotypes will be represented after it has given the report. So this is simply S, then we'll have maybe SS, or we'll have A, and so on. Then it will give you a representation of the interpretation. So based on the algorithms by the manufacturer. So like here, AS, it will likely sickle cell trait. AS, if you get SS, it will give you sickle cell disease, and so on. So the interpretation depending on the image on the machine. So remember, we started with our band labeled here. Then the migration happens within the 8 minutes. Remember, this is the marker fluid. You can see it on the end. So this helps as internal QC for each particular sample as they migrate. How it happens, or the back end of it. So there's a high-speed camera that is inside the analyzer. It's recording the video within that particular 8 minutes. It's actually recording how this particular movement is happening. So based on the algorithms by the manufacturer, you'll find that it kind of represents the normal movement of the blood. And if there is any issue with this particular movement, you'll get errors. So if you find that the marker fluid is not migrating at the speed that it's meant to migrate on, it will give you an error. So that might be represented by maybe the paper was not sufficiently wet, or after paper wetting, we waited for long before we loaded it on the analyzer and the paper dried, so hindering the migration of these particular bands. So that's how you'll be able to pick out from the camera, and the software will also be able to evaluate if the movement is correct. So we have the location. So the location is this particular distance. So at the back end of the software, this is how it's seeing the representation. So it's representing it as a wave band. So you'll find the S band will be represented at this particular level. A2CE will be represented somewhere here, and so on. So remember, as I said, depending on the time. So as we move on time, these particular aspects are migrating, and the location will move further. So if you give it a lot of time but no movement at all, that's represented by the A2CE. Then you'll have the S, then you have the F, and you'll have the A band. So usually A moves, it's the one that moves much further, and usually represented as this particular band. Then you have the marker fluid. Now remember, as I said, the marker fluid is calibrated to move at a certain speed. So this is what is usually represented, and the software will pick out how much, at what speed it was moving to confirm that it was okay. So issues to do with marker fluid not migrating will be either it is expired, it has exceeded the open vial stability, and so on. So that's some of the things that our clients will use in terms of troubleshooting, and then gives us the representation in a percentage, and then we evaluate. So management of the disease, you find that patient education by hydration, avoiding triggers, early treatment of infections usually helps manage them. Vaccinations like pneumococcal, meningococcal, influenza. So this one represents by helping them reduce the disease burden in case they have any infections. Prophylaxis like penicillin prophylaxis in children, folic acid supplementation, treatment of acute complications like pain crisis, usually hydration, oxygen, analgesics, transfusions if needed. So this usually in case the clogging is happening at certain points in the blood vessels, usually causes pain crisis at some points. The acute chest syndromes, antibiotics, oxygen transfusion. So this is just general measures in terms of patient management. For stroke, urgent transfusion, chronic transfusion program usually alleviates that particular aspect. Disease modifying therapies. So this is the hydroxyurea. So you find that hydroxyurea will increase the HbF, reducing the sickling and sickling crisis. L-glutamine reduces the oxidative stress and frequency of pain crisis. Voxelotor increases HB affinity for oxygen, reduces hemolysis. Crisanlimab, monoclonal antibody against P-selectin, reduces vaso-occlusion. Curative therapies will be bone marrow or stem transplant, so that they are able now to start producing the normal hemoglobin. is usually limited, but limited to donor availability and the risks of that particular procedure. Gene therapy by gene editing. So we have the CRISPR. So it's being used in studies, especially in the UK and US. So they do the gene editing by using CRISPR. So CRISPR will go and target the codon 6 and then edit or cut out that particular gene that is associated with changing the beta globin chains. And by this particular process, by eliminating this, especially on an early stage, you find that now the gene mutation is not happening and helps in reducing that particular disease representation in the patient. On the marketplace, so as Keton, we also do supply this particular analyzers. So this is just the process of it. Once we put our marker fluid and blood, they'll migrate, and then we'll have a gold standard representation of that particular result. So very accurate machine. It will give you the percentages, helps in monitoring, and also very cost effective. So these are the references for the particular for today's presentations. We have the Physician's Guide by Gazelle, Hemex Health, and other references for your review. Our contacts, and thank you for attending our webinar. So we'll open it up to the Q&A section. Antony.
Thank you very much, Haroun, for the beautiful presentation and knowledge sharing in terms of the sickle cell diagnosis. So I would allow question and answers. You can type your question on the Q&A section or on the chat so that we're able to pick them up. I can see a few already up. So as we wait for you to do that, maybe I'll allow John King just to share some words, and then after which we can be able to be on the Q&A section.
Thank you so much, Jack. Thank you so much, Ayub, for a fantastic presentation on Gazelle. I think you've spoken very clearly on the scientific part of it, as well as the technical aspect of it, interpretation of the results, and also differentiation between the two different kits. I know some of our customers have used the old cartridges, and there's also the variants of the new cartridges. So sometimes when you talk about 8 minutes, those who've used the old cartridges will definitely have a different argument. But with the new cartridges, then we determine that exactly what we're talking about, 8 minutes. That's another 2 minutes of sample prep comes into play. So I appreciate it. Thank you so much. I can see quite a number of questions, and I'll leave it to you, Jack and Ayub, where you need my help. Then, yeah, I step in. Thank you so much for that presentation. I appreciate it.
Thank you. So feel free to unmute and ask your questions. So as we wait for that, we'll go straight to the one on the chat box. We have Onyango Eric Omondi. He's not told us where he's from, but it's okay. So he's asking, is Gazelle HB electrophoresis machine approved for testing, or is it for screening purposes? So we do want to pick up that, John?
Yeah, so yeah, I can take that one up. The HB electrophoresis Gazelle is used for both functions. We did a validation study already at Jaramogi to qualify it as a diagnostic tool as well, and also in many other countries in Africa, including Ghana. It has been validated for diagnosis in Nigeria as well, in Tanzania. In recent past, we've also done a lot of validation study and comparative studies with Biorad D10 to qualify it as a tool that is suited for purpose. So that the long and short of the answer. The answer is yes on both ends.
Thank you for that.
Use it for hydroxyurea therapy monitoring in some cases, as well as transfusion monitoring, because of course you need to monitor the fetal hemoglobin when you're dealing with hydroxyurea, and also you need to monitor the increase of A trait as you do transfusion therapy, because there's always that impact on both.
Okay, thank you for that answer. I hope Onyango, you've been well answered there. Still the second question from Onyango. What is the cutoff point for one to be HBSS? As a machine called Biorad D10, the cutoff was 40%. What of the Gazelle? I don't know, the Haroun, you want to pick up that?
Yes, I'll be able to pick it up. So cutoff for HBSS as a machine called Biorad D10, the cutoff point was 40. So this one will be represented, we have the physician's guide that usually helps, and usually the cutoff for this is usually represented depending on the sample that we are running. So we have, if you are running the infants or if you are running the adult, and you find that for Gazelle, the representation usually starts between 40 to 60% of the SS. So for SS, so you find that the highest percentage of S being represented will vary on the interpretation bit. So usually around between 40 and 60%, but the minimum still remains the 40%, same as HPLC, because Biorad D10 does HPLC testing, while HB electrophoresis for Gazelle using the electrophoresis method. So comparison between HPLC and the Biorad D10 HPLC is similar. So similar cutoff for 40%. Once you get below that, it means there is other representation of either F or other representation of A.
And just to add on to that, also always remember, in the lab, maybe we never get the history of the patients, but in some cases, we find an impact again on the choice of therapy that has been meted on the patient. So if you have a patient already with the recent transfusion, then you'll have differentiation of those percentages with a little bit of an increase of an A, but still representation of an SSG. But yes, in comparison to D10.
Okay. So still from the same another question. Why does the machine doesn't have its own external QC? I don't know what that means by that. Why does machine not have its external QC?
I think I can take. I don't know whether I can take that, Ayub. Then you can chime in. Well, from Hemex, we don't manufacture quality controls because the machine is built up with internal QC methodology with an AI built to it. But if there is a need for external quality controls, we have qualified some manufacturers with external quality control. We've been able to offer this to some countries that are in need. For example, in Tanzania, it's a great need to have this. So it all depends. The answer from my end is that from Hemex internally, we don't manufacture internal controls, but if there is need for external controls, then we can also equally give you and make that provision through Kettle. Ayub, over.
Yeah, that's okay. So the controls are available as external QC, so you can be able to have those, but if needed, you can always request from Keton for that.
I have a question. Hello.
Yes, proceed.
My name is Onyango Eric. I had a patient whom we had a contrary result. Until now, we have never issued out the result. The patient came as a non-sickler, but we weren't told. So the lab just subjected the patient to Gazelle HB electrophoresis. But initially, the patient had been tested somewhere with Biorad D10 HB electrophoresis, and this patient had a results. She was just coming for confirmation. She's a 4 years old female, and I have her result with me. If you can have somewhere, or I can just read around. Her results set this way: the A2, C, and E. You say they coagulate. The range that the result gave was 2 to 9%, and S was 53%, F was 40%, and A was 7%. Note that there is a A of 7%, right? And there is the interpretation that we were given was likely sickle cell beta thalassemia disease. That is SB. That is phenotype. Phenotype came out as S, F, and A. But in Biorad D10, the result that the patient had, the patient was SS of 70%. You know, Biorad give you S of particular percentage. So my question is, this patient is a true sickler, right? But is having A of 7%. So maybe you help me explain that, or maybe it is us, we got it wrong because we did it several times, like 3 times. The results still come the same. So kindly, can you explain for me these results, please?
Okay, thank you. I'll be able to pick that one up. So first thing you need to know, Eric, this particular diagnosis is based on representation or the clinical history of the patient. So as a lab, what you need to know is this particular result that was diagnosed with Biorad maybe D10, when was it done? And the duration between that particular test and your test at the lab, how is the duration? Number 2, you need to find out, has the patient been on treatment, either hydroxyurea or transfusion? Because usually once you do the run, you'll find that it will clearly indicate to you transfusion might impact results. So you need to have that particular history for the patient. So if the patient was tested at this particular time, the doctor has already started the patient on medication, or they have started a transfusion to manage the patient, the representation of those percentages will change at what point you are doing that particular test. So the repeating of the test does not matter if you do it 1 or 2 times or 3 times at the same span, but it will differ if you are doing it at different durations and how the patient is being monitored. So at the back end of your analysis of the results, make sure you have that particular information either from the doctor at the facility that you are at, or the referring doctor. So, because if the patient has been subjected to any medication, or is already on treatment or management or transfusion, that will give different results. So you find that if a patient comes to test, I'm a complete sickler patient and I get transfusion, if you take my sample the next day and test it, you'll find that A will be present, because what has happened is that I've been transfused with normal A hemoglobin, and that will raise the percentage. So it usually deteriorates over time, let's say between 60 days, the normal duration that RBC stays in the blood as they get cleared out. After that, you find that now your normal representation comes back as SS. But frequent transfusion will impact that particular result, because definitely in that sample of blood that you have picked, you have the transfused blood part of it. So you'll find the percentage will change depending on at what duration the patient was transfused. So if the patient was transfused maybe 30 days, you'll find the percentage of A will be different from at a test that will be done maybe after transfusion of maybe 45 days, or at 60 days, or at day 1 of transfusion. So the clinical history is very important while you are giving out that particular report. The machine will give you the correct kind of representation, because that particular A2CE, the A2 is being represented as 9%. That's why it's representing it as the thalassemia. So remember when we said A2C and E, so A2 is known for that particular aspect. The A will
be present only if transfusion is done on the patient. The F will go up if the patient has been on hydroxyurea therapy, while the S will go down if the same patient is also on hydroxyurea therapy. So depending on at what point the patient was tested and the management of the patient, and also at what point you came to do the retesting, the results will vary depending on those particular conditions.
Thank you so much. That's a nice explanation. Thank you.
And if I may add, Mr. Nyango, I think Ayub has really indicated it well. And if I get you, the SS on B10 was 70 at that particular point, and then you're looking at an S of 53%. Is that correct?
Yes.
So you're still on the cutoff point of the Sickle of above 40, which is the same. So depending on that particular history, as Ayub has indicated. However, if at all you want more clarity, no problem. I think Ayub, you can pick up the contact, share the physician guide, and if possible, we can also get the data file of that specific test, and we can equally analyze just to clarify it further, and we'll be able to tell you in the migration what possibly happened along the chain. If there was therapy intervention, then definitely with the electrophoresis, you will have that kind of a representation. Again, these are two different technology approach. HPSC and HB electrophoresis are two different technology approach with good concordance at the same time. So yeah, it would be interesting to get to know more the history.
Please pick my number because we have a very many results that usually we have some doubts, please.
What's your number?
So from which facility are you, Onyango? Are you able to hear us?
From Baraka Health Center, German Doctors, Madare.
Okay.
Baraka. Okay.
Yes.
All right. You can still organize and schedule a CME for your team so that they're able to be well versed on how the interpretations and the clinical aspect of integrating lab clinical in teams in terms of getting the patient history and also the lab intersection so that you're able to have better diagnosis. But you'll share your number on the registration or on the chat box so that you're able to reach out for you. I don't know, John, you are talking?
No. Thank you. I think you will be able to pick Eric's contact details and make.
All right. I think Eric had one of the many questions. I think the forum has served to really answer most of his questions, and also mechanism for follow-up so that we are able to clarify some of the issues. So I don't know that I should proceed some with his question. SB10 is so challenging and it end up wasting our kits unlike S10B manual one. Why? So Haroun, I don't know that you want to pick up some of those questions.
Yes, I'll be able to pick. So for that, I will still go back to maybe the initial training that you received from your current distributor. So we'll be able to figure out that with you. I think you either need a retraining or another session for that, because the pre-analytical aspect of the process is most important as per my evaluation, because the two different kits, the S10B is the easiest one to use, unless you're having an internal challenge at the lab. We'll be able to pick out why you are having such, but it's one of the easiest kits to use as compared to maybe the manual. So if you are having a vice versa kind of approach, maybe we'll be able to get in touch with you and do a refresher training for how to use those particular kits.
Sorry.
My final question, please. You just allow me to answer to ask my final question. Please, can I?
Proceed.
Yeah, thank you. We have a two gazelle machine, but one of them broke down. And the one that broke down, the engineer came and installed the two systems, the S10 and S10B, right? But now the second one, the engineer brought it when it's not subjected with that S10B. So the kits that were brought was S10B. So we use the kits for S10B in S10 machine because S10B had not been installed in the machine. But still, the machine gave us the results. So my question is there any impact on those results, bearing in mind we use the wrong kits on the wrong machine that has been integrated? And what is the impact of those results? Or is the results still the same? Thank you.
Okay, so for this one, I would say it's always good to follow the manufacturer's instructions. And as per the S10B kits, the manufacturer clearly tells you, remember on the video that I played, you need this particular version that is higher to be able to use it. So it will definitely affect how that particular interpretation is happening, because these particular two kits are prepared differently. You find the S10B is an upgrade of S10. So in terms of interpretation, the kit is programmed to read this particular kit depending on which version you are using of the kit. So to simplify, the response is you need to follow the manufacturer's instruction on it. And for the kit, if the machine is using the old kits, we need to upgrade that particular kit. So in essence, the engineer should have upgraded that particular machine before you start using the new kits on it. Using the other kit on this other one is a shortcut, yes, but I wouldn't say it's recommended, because when the manufacturer was doing this particular analysis on this particular kit, they were clear. If they were able to allow you to use this other old software version with the new kits, they would have indicated that. So it's a shortcut that is not recommended. Yes, you got the results, but it definitely impacts on how the representation is. And remember, whilst the manufacturer is upgrading this particular kits, it also affects how much time the migration of those particular bands occurs. So as John King was mentioning, it's clearly on the 8 minutes, you'll be able to see it on the new version of the kits, while the other kits might need more time, especially at the end. So it's not giving you exact 8 minutes, but at the end, you'll find that it's finalizing that particular migration to ascertain which positions they are, especially when it's focusing on the marker fluid. So on the old kits and the new kits, there is some variations, especially on the software bit, how the machine is going to interpret those results at what point and what point. So simply you need to follow the manufacturer's warning. So because if you saw that particular box of kit, it has a very big sticker that says only version this and this and this is to be used when doing the analysis. So I would say that is the aim of it. So if the other machine has a problem, this other unit that you are using needs to be upgraded for you to be able to use that particular kit. So following the manufacturer's instructions usually limits these particular errors, especially when you are doing that particular run. So we shouldn't do the shortcut of using another kit in a different section. And you see when the machine is upgraded, you have two sections. So you have the S10 and S10B. So the focus is, it's not just that it will give you on-screen video instructions to proceed, but if you skip those particular video instructions, you can now load the kit on the machine. Remember, the material used for these two kits will be slightly different, and also the time aspect of the software that is interpreting those particular results will also vary. So it's very important for you to actually use the right section for analysis, and you'll find that you'll have zero errors or zero challenges when using those particular kits. So the highest point that might lead to your question where you are saying the S10B is challenging or it's hard to use or interpretation might be because of those particular issues of not following that particular procedure or using the vice versa form of the interpretation. So the analyzer is not able to, if it was doing with 8 minutes for S10B and required at least more time for the S10, you'll find that it's giving you challenge and it will abort that particular test because it has not followed the protocol that it was designed for. Maybe John?
I think you are spot on. And Mr. Nyango, I would like to possibly ask this question back to the same results, the initial result that the first question you asked. Was this patient tested on, rather, did you run it on an S10B or an S10? And if you ran it on an S10B, was the reader updated? That is the first part of it. And the other question that I also didn't get is on the wastage. There is more wastage. Wasn't very clear on whether it is wastage on S10 or S10B. Somebody repeat that.
Oh, thank you. For the test that we did, the machine had not yet crashed down by then. So we did the S10B in the specific slot of S10B. And
okay.
yes, and then
the machine was already updated. Okay.
Yes, that one was updated. The one that was updated is the one that broke down. So the only version that we had that has not broken down is the one that was not updated now, S10. So, and the manufacturer brought bits of S10B. So we tried calling the engineer to come update for us, but I guess there was a delays and all that for over 2 to 3 weeks. So we tried if it is possible, and we saw that it can produce the results. So though we were so doubting, we were unable to give the result, because that's why we wanted to ask, is there effect when you use a different kit on wrong updated version? Yes, software. Yes.
There is definitely an impact, as Ayub was indicating. There would always be an impact. What we've learned from us, because also some of this point of care is always a learning process along the chain. In different places, you find that, and that's why we always pick up the data files, is that at the initial stage, you do 1, 2, 3 tests with the old software. You most probably will pick up, because again, remember the interpretation of result is stored on an AI memory kind of interpretation. So, but over time, if you leave it as that, then you'll definitely have an impact. And in some cases, it's able to pick immediately. The ideal situation is to update the software and ensure that you're on the right software so that you don't get variations. So that's the long of it. And I think in this particular regard, I would recommend that our colleague Ayub could visit and have a look at both machines, both readers, and then just to be clear that everything is in order, and then do some bit of rerun. If possible, if you have a known sample SS, that would be a good starting point to kind of use it as a baseline in terms of comparison. Mr. Nyango, you had a question. You also mentioned about wastage of kits. Which specific one were you talking about?
On wastage of kits now is S10B. Initially, when it was brought, we wasted a lot of kits. I guess now that was part of the user not from your side now. So I've learned something. The way we prepare sample and the way we allow the paper to wet. Thank you.
Yes, normally you'll find that wastage is predominantly at the initial stages because of you're used to the old method of wetting and also stamping. And in this particular regard, it's much simpler in a different way with a specific timing. Like, for example, when you're doing 5 drops, if you do extra drops, then you have a problem. If you have extra time already on above the 20 seconds that you're looking in terms of dipping, then most probably you also encounter some problems. So I appreciate the fact that you notice that it could be a user issue. If you need a retrading, we are more than happy to assist.
I suppose
Okay,
he needs training.
okay, to finalize on diagnosis of children. So for HB gazelle, if the infant that is being tested is above 37 weeks of gestation, then it's possible, as long as the gestation period was 37 weeks. So 36 weeks and below, it will be limiting. And also, if you are testing the child for beta thalassemia, it should be above 6 months of age. But for sickle cell screening, above 37 weeks of gestation and after birth, the machine is suitable for testing. Then after 6 months, a confirmatory test is also usually done because at 6 months, the F has receded and A is predominant. So it can easily confirm the AS trait for the infant and also the SS disease for the infant. But from 37 weeks of gestation up to 6 months, gazelle is also used for infant diagnosis. So the important bit of when you're selecting the patient demographics, if you indicate an infant, if there is beta thalassemia trait in the infant, the report will not be generated because at that point the F representation and A to CE is not accurately identified for 37 below 37 weeks of gestation kind of infant and should be tested above 6 months. So in simple terms, yes, it can be used for patient diagnosis and the software will be able to interpret the results for you, either to give you the beta thalassemia or not give you the beta thalassemia trait for that particular infant. But for AS and SS kind of reporting, the machine should be able to give you clearly.
All right, Onyango, are you satisfied with all the questions that you asked, their answers?
Much satisfied, very satisfied. Thank you.
Thank you very much. So I think what's coming out is that I normally go back to my quality grounding because when we don't do the installation qualification properly and operation qualification and also performance qualification of equipment, we tend to struggle along the way. So when the user training is not done well and you don't follow through how an equipment should be able to work, we tend to struggle. And then also the verification process versus the existing gold standards. So I think it's an area that we picked, and then our team will be able to reach out to you just for a user training. Any other question? Somebody can feel free to raise their hand or to unmute the microphone. I think we have only 6 minutes. I don't know if I've missed any questions on the Q&A section. And I think Onyango was the main person who was asking questions for the majority. So
Any comments from the
any comments? Yeah.
Looks like we are good.
All right. I think it looks like we are good. We don't have any questions or any comments. Feel free to reach out to Keton. We recently sent the technical support mechanisms for HB Gazelle users in Africa. So in terms of user problems, in terms of anything that relates to Gazelle, in terms of use, you can feel free to reach out to us. I think Haroun will be able to put up his contacts on the screen so that you are able to reach out, and also John Keane. John Keane is the manager for Africa, so maybe also the two contacts will help so that in case you're having any difficulties, you're able to reach out. So Keto majorly distributes Gazelle in our Ugandan market, while we do offer technical support for the Anglophone Africa. So feel free to reach out to us in case of anything. So I'll take it back to Haroun and John King, and then we'll be able to wrap it up at the top of the hour. Over to you, Haroun.
Okay, thank you guys so much for making time to attend the webinar. Thank you, Lucy, for your well-received comments. Thank you, Arnold, for the comments as well. We appreciate your attendance. And as always, we'll be able to share the presentation for further reference with you as per your registration. And also, we'll be able to share the CPD points for registered participants and also the certificates of attendance. We'll also be able to share the YouTube video for these particular presentations as well for further reference. And we hope to interact with you in our future sessions. So my appreciation is to you for making time to attend, and thank you for indulging with us. Thank you, Onyango, for your queries, and as we've picked, we'll be able to assist you with technical support from the current distributor. We have Gazelle technical support team. We'll be able to assist you in that, and we'll be able to contact you so that we can schedule a training session and also an update for your analyzers, and we'll also be able to handle any queries that you might have. So those are good feedbacks that we have given, and we'll be able to interact with you more. So as a user. So thank you.
Hi. Thank you. Thank you, Jack, and the entire Keton team for organizing this and inviting me to be part of it. It was a great honor. For today, our guests today, thank you so much for making the time early in the morning. Really appreciate it. A day for learning great stuff, good science, the interaction. Mr. Nyango, thank you so much. Baraka is one of our main facility, been a reference point for us for many years. And we definitely call on us anytime you have issues. We recently made a few changes, not really changes, but to add more capacity in terms of support. We appointed Keton as a local partner for English-speaking Africa to support technically all our customers across. So in any event you have any issues with the reader, application issues, you have technical issues, questions, please feel free to reach out to Mr. Ayub. He has given out his contact. Also, would reach out to me. I've also given my WhatsApp number as well, and we'll be more than happy to assist. This is aimed at ensuring that there's a fast and timely intervention and delivery of back to information, because we all understand the importance of sickle cell disease today and how long it has taken for our population to be tested and interventions to be made. Intervention tools like, for example, Gazelle in this particular instance is bridging the gap between care to, diagnostic to care. And we definitely would love to have more and more interaction in this manner. Love to support. We like to hear more success stories. We love to get feedback. Some of the challenges. It's also a learning curve along the way for all of us. We're all scientists, and we can always put our heads together and find the best way possible. And we are here to support. We are here to give feedback. And we thank you so much for all the time and dedication. Appreciate it. Thank you very much.
Thank you very much, everybody. And as usual, 3 CPD points will be awarded to the participants. And I think so far we've not had any hitches in terms of that particular intersection. So, Andrew, thank you and have a good morning. Bye-bye.
Thank you. Good morning.
Thank you and have a good day too.